We are from San Francisco, from where the American Diabetic Association meeting is going on. We have with us one of the international expert with us, Dr. Kamlesh Kunti from UK, Leicester, University of Leicester, Professor of Diabetes and Cardiovascular Medicine. So, Dr. Kamlesh Kunti, who regularly visits to India also for many of our meetings like Diabetes India. So, I just want to ask Dr. Kamlesh then what we are looking for American in this meeting of ADA, mainly for Indian delegates.
I think there's a number of areas. As you know, the hypoglycemia is an international area that everyone's interested in. Some good data from the HAT study, which has shown that there seems to be higher rates of severe hypoglycemia in Indians. We don't know why compared to many other countries. So there was a good session this morning on hypoglycemia, a debate between David Matthews and Thomas Pieber, asking, is cardiovascular disease a cause of hypoglycemia? And I think we'll never get a randomized controlled trial to get someone hypoglycemia compared to not giving hypoglycemia to someone, because that would be unethical. But all the epidemiological studies and some of the post hoc analysis of the trials do seem to show that hypoglycemia may be causal.
So one very interesting thing, because there are a lot of Indian companies who are also using the sulfonylurea, and Indian doctors also use.
Yes.
And in India, after coming the DPP-4 and SGLT2, when they came in the market, this hypoglycemia, everything, we started talking also in India.
Yes, yes.
So do you think, the Indian doctors and sometimes even the Indian pharmaceutical companies are also thinking that it is overhyped by these multinationals who are making anti-hyperglycemic agents because they don't have the hypoglycemic agents, by most of the Indian companies who are selling the sulfonylurea, and many of the older Indian physicians also consider that the hypoglycemia is not really so high in the real world data or real world practice. So is it overhyped?
I certainly think so. Hypoglycemia is obviously an important issue, but in terms of sulfonylureas, if you look at the randomized control trials, mainly we're looking at UKPDS and Advanced, both of them showed that there were beneficial effects on microvascular outcomes. In Advanced, they used glycoside, which did show a very slight increase in severe hypoglycemia. We've done work, a recent study, a prospective study of 12 months of diaries, and it shows basically severe hypoglycemia not a major issue with sulfonylureas. But there are differences between sulfonylureas, and glimepiride and glycoside seem to have the lowest rates of hypoglycemia compared to the older ones, such as glibenclamide and chlorpropamide, which are the ones we shouldn't really be using. However, countries like India and many other developing countries, they do have an issue in terms of access to these therapies. But the WHO access therapy should be really glycoside rather than using glibenclamide.
So one more thing, after this continuous glucose monitoring came in the market, particularly in India when AGP had come, ambulatory glucose profile, which is really cost effective in India.
Yes.
We also started realizing that yes, hypoglycemia is a major issue.
Yeah.
But the problem is most of the Indian diabetic patients average HbA1c is around 8 or 8.5.
Yeah.
So probably in real clinical practice, the doctor or physician might not have appreciated the hypoglycemia.
Yeah.
But if you achieve HbA1c less than 7.5 and then you do the continuous glucose monitoring or something like ambulatory glucose profile, then you will be able to realize more of a hypoglycemia.
I think absolutely. So I think the flash glucose monitoring, ambulatory glucose monitoring have given us now a method of diagnosing hypoglycemia in people we didn't know were getting it. I think all these devices are really good, and you don't need to use them long term, especially in type 2. Type 1, definitely.
Yes.
But for type 2, we've been advocating using them as a screening tool. So putting a patch on someone and saying, do they have hypoglycemia? If they're not getting hypoglycemia, then you could go lower. Or if they are getting hypoglycemia, maybe changing therapy, maybe changing the target HbA1c you're going for. So I think as a diagnostic tool for type 2, they're really good. In terms of management long-term for type 1, definitely there's no doubt about it.
So, other than hypoglycemia issue, any other issue which we are looking for?
I think I'm excited about the REWIND data.
Yes, so we all are looking forward for the REWIND data.
Yeah, the top-line results were that they met the primary outcome. And that showed that the 3-point MACE was, I think, positive for dulaglutide compared to placebo arm, which is in line with semaglutide and liraglutide as well. It'd be nice to see what the other data in terms of the components of the MACE outcomes. Are there any beneficial effects there? And obviously, they hopefully will show some renal data as well.
What about Carolina?
For Carolina, we again know the top line results there, showing that they met the primary outcome in terms of it was safe, but they didn't seem to show superiority. Now, I may be wrong, but that's what I read from the top line results.
Yes, the top line results are showing not superiority.
Exactly. So I'm presuming again showing that sulfonylureas may be safe to use.
So that is what when hypoglycemia we are talking one side it
Absolutely.
increases the cardiovascular, other side we are saying the sulfonylurea. It's not superiority shown by the
Exactly. So I think that the hypoglycemia is an issue, especially certain patients. But insulin is the main culprit for hypoglycemia in people. I think sulfonylurea is less so.
So any other than this, any exciting news for?
I think there's some good mechanistic stuff that's being shown. For example, the direct trial, the reversal of diabetes by the 800 calorie diet. That should be good to watch because I know Rod Taylor is going to be talking about improvement in beta cell function as a result of this. Now, I don't know what the data are, but that will be quite interesting to watch.
Yes, that's really very interesting. It had come in the press also in a big way last year. This and anything about newer insulin, which is
well, there are post-hoc analysis of the BRIGHT study. There's also the Degludec trial.
So, do you think this is the difference between the in BRIGHT study which they had shown between the Tuzio and Tresiba? Is it really clinically?
It seems to be that there is a clinical benefits of the second generation longer acting basal insulins. Now, it's difficult for the head-to-head comparisons because Novo Nordisk also have a trial with
similar type of trial.
But the patient populations are very different. In the BRIGHT study, there were insulin-naive patients, while in the Degludec trial, these patients have established disease and they're already on insulin. Okay, so I think it's difficult to compare the two populations.
In India, these newer insulin are slightly costlier in compared to the older basal insulins. I mean, in compared to Levemir and Lentas, the Tuzio and the Tresiba are costlier. While in other parts of the world, they had kept almost similar cost. And we have also now the Glargine, which is available with a lot of other biosimilars.
Yes.
And the Levy also is available in India and other.
Yeah, we've got the same issue in the UK, for example. They are pushing for the biosimilars even before Glargine.
Exactly.
So, we have to use the biosimilar first, and if biosimilar are associated with hypoglycemia, then we can consider the second generation longer acting.
So because the cost effectiveness of these newer basal insulin analog, and they are costly, particularly in India.
Yes,
so
of course. Yeah.
They think twice before using it.
Absolutely.
Many other Indian physicians.
Yeah.
Thank you. Once again, thanks, Dr. Kamlesh.
Thank you. Thank you very much. Thanks.